There's enormous potential for mobile health to extend the reach of our health systems to the world's most marginalized populations through more timely information and more powerful decision support tools at all levels of the health system. However, we can only achieve this if information collected by a frontline worker during an antenatal home visit can be viewed by the midwife at the clinic when the soon-to-be mother arrives for her delivery. This same information can then be integrated into district-level systems for reporting, inventory management systems for monitoring of supplies, or vital registries for tracking of births, deaths, and immunizations. Interoperability in such a complex ecosystem necessitates greater adoption of international health informatics standards. Standards are created by standards development organizations, which are generally funded by governments or private sector members who have a business, health, safety, or economic interest in broader adoption of that standard. For example, widespread adoption of standards for cellular networks are the reasons that a phone purchased in India can make calls in Zambia, because almost anywhere in the world, the networks were built with the same equipment and the phones communicate using the same protocols. This results in lower costs for governments, industry, and ultimately consumers. And when standards are done right, rather than restrict markets, they actually foster innovation. Just think of all the innovation that has occurred at the end of a USB stick. There are 5 types of standards within health informatics: data interchange, semantic content, security, safety, and privacy, pharmacy and medicines, and architecture. There are just a small number of organizations leading the health informatics standards development effort globally. To name a few, the International Standardization Organization, the European Committee for Standardization, and Health Level 7. After a standard is created, vendors and implementers may purchase and implement it. Alternatively, governments may enact policy in cases where the private sector does not pick up a standard on its own. So we've looked at the standards development process, but how does a low-income country actually use these standards to improve interoperability and health delivery? Let's take a look at a common maternal health example. A community health worker identifies potential gestational diabetes at a pregnant woman's home. She uses her cell phone to add the risk factor to the woman's electronic health record. Several months later, the mother arrives at the clinic for her delivery. A midwife pulls up the mother's electronic record at a computer and notes the potential complication, which prompts a blood sugar test and closer monitoring of the infant for several hours after delivery. The outcome of the birth is recorded in the mother's record and in the National Vital Registry database. Even in this simple scenario, there are already numerous standards at play. A standard for unique identifiers ensures that the patient information is stored in the right place and can be retrieved later. Messaging standards are used to send information between the systems. Terminology standards make sure that the pregnancy risk factor or diagnosis or procedure all mean the same thing, regardless of what system they're in. Finally, architectural standards provide guidance for how all of these pieces need to fit together. Without these standards, each government, vendor, or doctor is going to use their own proprietary methods, which results in incompatibilities. And these incompatibilities are not just expensive to address, but they can even cause deaths. There are 3 major contributing factors to why standards adoption is low among low and middle income countries. The first is limited participation in the standards development process. In fact, in 2011, only 8 low and middle income countries were contributing members of the Health Informatics Technical Committee at the International Standardization Organization. The second reason is lack of alignment among donors and other multinational organizations. A coordinated approach to e-health standards would enable strategic investments and planning that set the stage for future interoperability. The third reason that standards adoption is low is the lack of access that stakeholders in low and middle income countries have to relevant standards and implementation guidelines. We need better information about what standards are available and how are they best used in such settings. We also need to make them affordable to the countries that need them most. The question before us now is how can governments and the international community work together to address these enormous challenges? The first is standards knowledge management, so that implementers and policymakers know what standards are available and how to choose the right standards to meet their unique requirements. The second is capacity building and establishing local and regional forums for standards engagement. Regional e-health standardization collaboratives would provide a mechanism for shared learning and help to pool scarce resources and expertise. The third area of work is supporting alignment between donors and multilateral organizations on standards. The fourth is bridging the standardization gap and improving access by increasing participation by low and middle income countries in the standards development process and advocating for making key standards available at no cost. Interoperability is fundamentally a reflection of human institutions. Standards are an essential building block, but it is up to governments, vendors, donors, and implementers to build an enabling environment that incentivizes the use of standards-based technologies to improve health outcomes for those most in need. Thanks for watching.